Hello, everyone. Thank you for joining us so quickly after what was pretty groundbreaking and provocative conversation last week with Dr. Lima. The list of questions we had during the seminar and also the webinar, sorry, and after is pretty comprehensive. So we thought it'd be great just to get on here and have a live Q&A. For now, I'm just going to kick it off to the experts with Lee Keddy, our CEO, Yvette Chapman, who is a industry expert consultant, and of course, the esteemed Dr. Lima. So thank you for joining us so quickly, Dr. Lima. We know how busy your schedule is. I think we're all excited about this opportunity. Thanks, everyone.
Well, thanks. Laura, that was awesome. It's great to be back. We meet again. It's like deja vu. A lot to talk about. We hope stimulated a lot of, conversation and just questioning kind of the status quo. I think that's what this is about. So much opportunity to save more patients. So, yeah, we can kick it off however you like, Lee.
Maybe what we'll do is, Yvette, you and I can tag team on the actual questions, and then we'll go from there.
Hey, Lee, one real quick thing. We have a surprise guest. Dr. Shroff is available to be added as a panelist. So
okay, perfect.
A lot of people know Dr. Shroff, so he's here.
Excellent. So that's a great surprise. I talked to Dr. Shroff this morning. Dr. Shroff doesn't need an introduction to most in the organ donation side, on the OPO side, and probably not even to a lot of the transplant programs. He's been with us for, I think, 8 or 9 years. Is that right, Dr. Shroff? Somewhere in there?
10.
Yeah, 10 years. There you go. And I've said this, I said this like 3 years ago. I did some back of the envelope calculations, and I think Dr. Shroff has read the most donor echoes of anybody in the world by about a factor of 5. So he's been involved in a lot of, with a lot of you in the OPO industry. So we reached out to him and just kind of last minute see if he could come on this, and he was ready. So this is fantastic. Well, good. So what I'll do is I'll share, it's just simple slides of the questions. I'm just going to share the screen here. Okay, perfect. Good. So we'll just shoot through these, and we've tried to group them. Some of them might be a little bit repetitive, and then we have some of the slides here if we have to refer back, but this is going to focus on questions. So Bebe Hafarana from Legacy of Hope: is time for this testing the same as for a regular CTA? Is the CTA for PTE acceptable to use for coronary calcification grading?
Yeah, so disclaimer, I'm not a radiologist, but I know enough to be dangerous here. But basically for any CTA, including the coronary CTA, you need IV access, right? And of course, I'm blanking on a scenario where a donor wouldn't have IV access, right? They're in ICU settings, et cetera. So by and large, we're all going to have ICU access, IV access. So the testing, I'm told, is roughly 15 minutes to get the test. I mean, the coronary CTA. So that's really not a lot of time. And it may take longer in the usual, non-donor situation where, again, they walk in there without any IV access. So it's just getting the IVs probably the hardest part. But once that's in play, then it's off to the races. It's a quick test. A CTA for so as we kind of got into a little bit, any CT scan, even ones with contrast, have a non-contrast phase. So it's that non-contrast phase where you could look. Also, if that's all you have, no contrast at all, you could at a minimum do some coronary calcification assessment. So the answer to that would be yes.
Okay, good. Go ahead.
All right. Sharon Rakowski from Donor Alliance is asking, what limitations would there be in the donor for the CTA, such as heart rate, blood pressure, body habitus, dye restrictions?
Sure. So for the, if we get to the point in the algorithm where we're saying we really want to go the full distance to vet the coronaries the best we can with a CT coronary angiography, those are gated to the heart rate. And in, again, the non-donor situation, the published literature, guidelines, protocols, ideally you want the heart rate, less than 70 or 80. So there is sort of protocols in place to administer some beta blockers to achieve that. Now, mind you, there's two important points about that. Again, I'm not a radiologist, but I've spoken to a few, and obviously we're going to go into more detail as we try to formalize this and scale it up. But in the typical, patient situation, they're getting worked up for maybe a procedure, and we're doing this coronary vetting. We're trying to limit radiation, and in order to limit radiation, there's a way to do so if you could have the heart rate be a little more controlled. In the donor situation, that may not apply necessarily. And number two, again, definitely outside my wheelhouse, there are methods radiologists can employ to do what's so-called retrospective gating, where they can gate after the fact with a little bit more radiation, but maybe overcome some aspects related to the heart rate being a little higher than than ideal. And it also comes down to what is it that we're trying to rule out. Again, in the normal clinical scenario, you're trying to assess for actual maybe occlusive coronary disease, et cetera. Whereas, as I kind of mentioned in our previous webinar, you're far along this algorithmic tree if you've maybe seen some calcium on the initial sort of what should be the initial universal screening for everybody, a non-garden variety, non-contrast chest CT. If that showed a speck of calcium or more, then at that point you might be progressing along to this scenario. But if you're seeing extensive calcification and things like that, that's where some of this fine-tuning, nuanced gating and controlling the heart rate may come into play. So there's literally, all this is blank canvas, right? This is uncharted waters, what we're talking about. And I definitely want to make sure that the main point here is that we do that initial screening with the non-contrast chest CT on everybody, right? And I think that's the lower hanging fruit where we may be missing opportunities. Far along that algorithm where we get to these sorts of considerations is where things can get a bit more nuanced. But that's basically the idea. In a perfect situation, yes, you would like the heart rate to be a bit more controlled. And sometimes beta blockers are used for that.
Thanks.
So just on that regard, before we go to other questions, it feels like even some of the discussions that some have reached out to us in between the last webinar now, it seems like it would be good just to go over some of the levels that we're talking about. So that the gold standard is the heart cath, correct?
Well,
and then a level almost getting equal to that is the cardiac CTA with contrast and gating. But this is where you're talking about controlling heart rate, et cetera, right?
correct. Yeah.
And then there's these levels above where you're using a basic CT, and maybe the easiest and most available is the CT with this bone contrast or not contrast, sorry, the bone Hounsfield, and you're looking for the calcification, and that's that first screening. Then there's this the ability to potentially have, or not potentially, to have that standard CT have a calcium score, which is has some AI and some post processing which we have available. And there's also the potential of having contrast with the regular CT, which often might be done for the donor for other reasons, and that has some additional visualization. Is that a fair assessment of those?
Yeah, that's definitely a fair assessment.
Okay.
And what you don't see, and I think that one of the questions further along in this sort of set of slides was related to a donor with lupus. And and I guess lupus patients can harbor soft, quote unquote, soft plaque, right? So by and large, yes, the majority of plaque, quote unquote, coronary plaque is calcified plaque, meaning it'll show up when it'll have the same density as bone. It'll show up as white on non-contrast chest CT. But if it's clean, you see no specks of calcium, is that necessarily 1,000 or 1,000,000% mean they have absolutely no plaque? That would be inaccurate. There, of course, is a theoretical risk of soft plaque. Well, a coronary CT angio gated to heart rate can pick up on that soft plaque. That's what you can't pick up on a non-contrast chest CT. That's not gated.
What is your threshold for patients with soft plaque, with potentially soft plaque, with the high risk factors, diabetes, hypertension, known hyperlipidemia, and a 35-year-old who's used cocaine?
Yeah.
No calcium. Would you want to get a CCTA or at least do some other studies to rule out soft plaques?
And this is where we get into kind of real world, what's doable to what the ideal future state would be, right? In an ideal, in the real world, what happens is, yes, we would say, okay, number one, great, no calcium, so no calcified plaque. Can we go a step further and do a contrast chest CT or even a Cath? I mean, our mantra is we will get what we can get. If all the way up to they'll do a Cath, great, all right. If they can't, can we do a coronary CT? No, sorry. Okay, well, can we get maybe some contrast, something, right, to take a further look? It's not perfect, but if that looks okay, and then you could go and assess the heart yourself grossly on visual inspection and see and make sure there's nothing there. It's never going to be a 1,000% yes, no worries at all. But I think that's kind of the stepwise approach we would go. But in a perfect state, you would want to get a coronary CTA if at all possible to see if there is some soft plaque.
And I think this is what you and I were talking about, Dr. Lima, a few days ago, is that it's important that we've got the more difficult cases. What this process is to rule in and rule out the more obvious, right? So, and I'm paraphrasing what you're saying, where if there's someone, say, over 45, and you can't get a heart cath in the middle of the night, but you have a CT and you can look for calcium, if that's zero, if there's nothing there, then that's a good indicator. So on the ones where it's, I think in your score it was none, mild, medium, moderate, the mild ones, or the none, that's more definitive. Exactly. Now this, and then Dr. Schroff, this case where they're young and that's not a good plaques or calcium is not a good indicator, that would be, again, an area where you might need more information. But in that scenario, those are ones that you can go after, like on a DCD case, where you might not have gone after them before. But then also was the other side, Dr. Lima, where if you see lots of calcification, then that helps you almost rule it out.
Sure. Yeah.
So those are ways that this tool can provide that better decision making. And where we see it being incredibly exciting is even on the potential donor. Like this stuff is available on potential donors visually. And for those of you that have used that have worked with CompuMed with Direct Connect and those sorts of things, we've also found out, you might have a CT for the donor that doesn't have contrast, but when you use Direct Connect, there have been CTs before they were a donor 2 or 3 weeks previous when they were in ER that had contrast. And this sort of thing is not something that changes like EF over 2 days in as they're managing. If the calcifications, those would be valid from 2-week-old CTs, right, Dr. Lima?
Yeah, and then just to highlight too, a coronary CT angio, I mean, it's very sophisticated to the point where you can even calculate FFR, fractional flow reserve. You can actually determine if there is a blockage, how much of a blockage is it? Meaning, do you actually have to do something like a bypass surgery or a stent because it's a significant, hemodynamically significant narrowing of the vessel. That's the level of detail you get with the coronary angio. And it's, in the clinical environment where we're determining on this 85-year-old that we're thinking about doing the transcatheter aortic valve replacement, are we going to do something about that 40% LAD lesion? No, we're not. We're probably going to leave it alone, because if you did a bypass, it won't stay open, et cetera. But that's kind of how sophisticated this imaging is. But I think most of us would agree that a donor that has a 50% blockage of something, probably that's it. If we're not going to, that's probably ruled out. What we're trying to see is if, are there a lot of lumps and bumps and things concerning for potential CAV down the road? I'm not so sure we're talking about full-blown occlusive, coronary disease.
Got it. Well, we'll just move on here. There's still a lot of questions, but this has been great. So from Cassandra Fail, RN of UCSD, taking a deeper dive on data and patient outcomes, were the deaths high-risk recipients going into transplant?
For the vast majority were high-risk recipients, and had really no correlation with whether their coronaries were assessed with CT versus invasive coronary angiography. The early mortality in both of those instances was equivalent, low. It really, when we do our kind of risk prediction modeling and everything, a lot of it does boil down to the recipient. Really complicated, multiple sternal reentries, LVAD, explant, things like that. Congenital heart patients who've had multiple prior open heart surgeries, things like that.
Just maybe a corollary on this. Maybe this is what she was getting at here too. I'm wondering if she was wondering that is this take a higher risk recipient to kind of go out on the limb in some ways of using this evaluation? That's not necessarily what you're saying. Is that correct?
Well, maybe yes. If maybe a lot of the folks on the call were around, I don't know, 15, 20 years ago when there was a quote alternate list for heart transplant. I know at Duke where I trained, we had an alternate list heart, and I actually published an article with Carmelo Milano in the Duke department on comparing outcomes, with alternate heart transplant. And those were basically donor hearts that were turned down by everybody. And, sometimes you had to do a bypass or something, or fix a valve on that donor before you implant, after you implanted it right then and there. So, but for these alternately listed recipients, super high risk, maybe not, this was a godsend. They did well. So yeah, there is a bit of kind of weighing the risks and balances of certain high risk populations, matching certain donors with certain recipients, where you may be willing to take someone with less than ideal, non-quote pristine coronaries. Maybe there's a speck or something near in there, but that's kind of what this is all about. There's not really a textbook kind of answer.
Just to clarify, what I was getting at was not so much the coronaries, but the method of getting the information. So I think this was maybe asked, and also if your recipient's higher risk, are you more willing to take risky data? And I don't think that's what you're getting at, right? Like that this is not risky if we keep it in the right use case. Even if you didn't have a higher risk patient, if you were next in line and you couldn't get a heart cath, you would use.
Yes.
Yeah. Okay. Good. Go ahead. Yvette?
This is a weekly occurrence at our institution.
Yeah.
Well.
Yeah. Good.
Jason Hasler, Senior Organ Recovery Coordinator at Southwest Transplant Alliance, is asking, is there something special we need to request or state in the actual order when ordering a non-contrast chest CT?
Not necessarily, meaning that in a perfect world, we would want a calcium score too, but that may not be something that's done at 2 a.m. at a hospital. A regular, non-contrast chest CT, sure. It doesn't have to be protocolized in a certain way. You should be able to see what you can see and determine if there's any calcification. But I think one thing that would hopefully emerge from all of this, at a minimum, would be some way to kind of kick that up a notch and come up with a way to maybe add or facilitate adding, whether it's post, processing, et cetera, the calcium scoring. That'd be great. But not really necessarily at the level of the donor hospital, because I don't think that's going to be realistic.
I'll add just a little bit to this. We've gotten, thousands of CTs, and we see all sorts of things that come in. Most donor hospitals, and of course DCUs that the OPOs have, they have a decent slice, like down below 2 millimeter slice. Sometimes we'll get CTs that are 5 millimeter slices, and in the DICOM, the actual slices are there, but it's interpolated in between. So as far as the technology out in the donor hospitals, there should be nothing special about the CT. You really need, it's best if you're 3 millimeter or less as far as how the processing comes in. So there's that first level of just the basic CT, all the ones you guys are sending us, that we can use. And then a CT, that same CT, we can also escalate that and send that to get calcium scoring, which has some AI in post-processing. The next step question really is about, it's really about contrast. And that's where there's opportunities to improve the AI with contrast. But of course, we know that there's some perceived negativity on getting contrast and the effect on kidneys, et cetera. So that's some areas where we're working on getting some more guidance on that. I don't know if that helps. Yvette, do you want to add anything there, or others?
Oh, I think that's good.
Yeah.
I guess one question that I would have, I would be on the abdominal side. I would imagine there are CTs being done with contrast for some abdominal requests, correct? Liver assessment, things like that.
Yeah.
And I guess the next question would be, how often does that scenario arise, or are there barriers to it in the DCD setting?
Yeah.
But this could be equivalent to that, I think.
That's actually a really good point, Dr. Lima. And we need to differentiate between DCD and the brain dead. It's very interesting because I think we've seen more and more contrast coming in. As we talk more and more to transplant centers, we see more opportunity, like for vasculature. When we do 3D volumetrics, we can do 3D volumetrics on a liver without contrast. We actually can split the liver without contrast, but it's better splits if we have contrast. We can do hepatic arteries if there's contrast, so now you have structure. There's been a lot of concern about contrast with kidneys. We've talked to nephrologists, and they're like, well, I can get better information if there's contrast. And so if you're holding back on contrast so that the kidneys aren't harmed, but the people choosing to take the kidneys would like the better information you get from it, it's this balance. And then as we see more and more things like the heart with contrast, I think we've worked with some of the radiology groups to develop a less dosage protocol for contrast that kind of balances those. So I think as we go deeper into this, we're going to find that the contrast has so many benefits as long as you manage it. And maybe in certain cases where there's higher risk, you don't do it. But I think as we see more and more of this value, that's going to be the opportunity, because it gives much better visualization on the images.
Right.
All right. Is it you or me, Yvette?
It's you.
Okay. Yolanda Becker, Chief Medical Officer of LifeGift. Actually, Yolanda's actually been significantly involved in some of the conversations even since, and she had quite a few questions. But we have to work through the allocation scheme, and talking repeatedly to a third party that is following an algorithm is a real issue. I hope this is presented at ISHLT or in a way that there is agreement with your colleagues and cardiologists. So I think that's me.
I know this is obviously, Dr. Becker brings up some great points. This is obviously an issue bigger than the scope of a webinar, but it's the truth, meaning this has to be taken to the next level. I think from our end, definitely everybody be working on a white paper and putting together some official guidelines around this. But this information has to be disseminated to all, because it's the right hand doesn't know what the left hand is doing. I mean, the radiologic associations, maybe professional, associations probably have little awareness of kind of this whole thing that's happening, right, unfolding on the donor side. So I think it's more just of kind of spreading the word. And again, I think there's some bigger picture things that need to happen. And the timing is right for this. There's a lot of change happening from a policy standpoint. In my kind of own limited research, one of the barriers to coronary CT angiography in general, independent of this whole donor environment, has been reimbursement on some degree. And actually, just this past year, the reimbursement from CMS for this procedure is doubling, or has doubled. Someone double check me on that. But basically, I don't know if it's happened yet, but there's talks of instead of it being under a sort of outpatient billing code to make it more of an inpatient. And that, I think, many believe will also facilitate kind of some of the, navigate around the obstacles that have kind of limited sort of more widespread application of these modalities, independent of the donor assessment stuff. Right.
Good. Okay. There you go.
All right. Emily Jones, an RN organ procurement coordinator, is asking, when entering these orders for a donor or requesting these orders from a physician in the ICU caring for these donors, can you please provide the specific verbatim order we should be entering or asking for, i.e. non-contrast chest CT with a calcium score or CT angiogram?
So my question about this question would be, and it's back onto the folks boots on the ground in the OPO land, isn't really everybody getting a non-contrast chest CT anyway? Or if not, why? But my retort to this would be, basically everybody gets a non-contrast chest CT. Mm-hmm. And as we've said, it doesn't have to be, it's just that. And the calcium score is something that I think will emerge potentially as an add-on to that post, processing add-on maybe. And if something emerges on the chest CT, then it would be dictated by the recipient hospital saying, okay, I saw that the non-contrast chest CT was done. There's nothing on there. I think, could we do, XYZ? No, we can't. Or yes, we could. We could do a chest CT with contrast. All right. And then there's a judgment call there. In a perfect world, if there's enough concern, enough risk factors causing a lot of consternation and everything like that, could you get a cardiac CT, a coronary CTA? But I think, just a non-contrast chest CT should be fine for everybody. And I think that's the bigger pool, the bigger pool of missing opportunities.
Yeah, and I think that's key here. Like, there's these gray areas where this is not saying to not get a heart cath. That's not what this is saying. This is saying that there's scenario, 55-year-old that is DCD, and you're pretty sure you can't get a heart cath in the middle of the night on a weekend, and you're going after the liver and the kidneys. But there's an opportunity here, and so that might not be offered. So there's an opportunity here to get the CT, to do an evaluation. If there's no calcium, that brings the potential up for this heart where that would not have been considered before. And that's kind of that sweet spot, right, Dr. Lima, where
and that's
offers you're not
that's precisely how this has occurred, kind of serendipitously, organically, whatever you want to call it, for our program. It's scenarios where the heart's not even being offered. And then we ask, well, whether we're vetting, our same coordinators vetting, the logistics for the liver, it's like, well, how come you guys aren't offering this heart? Like, well, and they look, there's a non-contrast CT, they showed it to one of us or whatever, it's clean. Like, looks pretty good. And then there you go, and off to the races. So,
and as far as the what to ask for, that's actually something CompuMed has been working on. This is really a decision matrix, and the beauty is the start is most everybody's getting CTs. If we can get these CTs, we can look them at that first level, and like I said, this really can percolate up really to the potential donor, because those things are available, especially for those, again, that are getting direct connect through CompuMed. You don't even have to be in the hospital, and you can ask for a CT, and so that can help in evaluation of things, hearts that you may not have gone after. But this is also like a funnel where you can use this quick scan, and if that's a definite plus or a definite no, now you don't have, it gives you more visibility to decide to go to the next step or not. And of course, that has to be layered over top what to ask for. But everything is really, in these tiers where you may not be able to get a cardiac CTA in the hospital. You may not be able to get a heart cath, but you can get the CT, and there may be a contrast CT that was done before, and so now there's an effort to go get that one. So there's these different levels. I hope that helps Emily with this question, but I think it's a fantastic question because we want to give people the ability to have a rubric in how to decide. Okay, number 8, and we're halfway through, so yeah. Go ahead, Yvette.
Okay. Stacy Dahl, Director of Clinical Operations at the Hospital for VAD, the University of Pennsylvania. Would you take a 45-year-old DCD with decades of lupus and tobacco use with COPS but no coronary calcification on baseline CT, unable to perform CT coronaries or angiography?
Yeah, so that's, I kind of was alluding to this scenario earlier. The concern for soft plaque, right? Lupus happens to be one of those illnesses that does have, if you look at the literature, some association with increased likelihood or of occult, maybe soft plaque being there that you would not see on a non-contrast chest CT. So that would be a tough call, a tough situation. If it was a hard no, where no additional imaging, not even a scan with some contrast, maybe not a formal, gated coronary CT, but a chest CT with contrast, just to step up from the non-contrast, maybe to help delineate that a little bit more. If that's out of the question, then yeah, maybe not. Right? It's a judgment call. It'd be a tough call.
This is actually really interesting, Dr. Schroff. You and I were kind of talking about this today, where really what we're looking for, so many of the things that have been asked for are proxies. And so in here, this lupus, and what you said, Dr. Lima, is really interesting because you said something about being the soft plaque, right? So really, what we're trying to find out more and more is what is the transplant surgeon really looking for, and what is this indication? What is this proxy giving an indication of a potential of? And we were talking about this, Dr. Schroff. It was like the occlusions of the artery, right? But they can be split into soft plaque and calcified plaque, right? So what we're really saying, I think, here is that the calcification can be seen in this simpler method, but the soft plaque cannot, right, Dr. Lima?
Exactly.
And so if there are indications, patient history that has a concern about narrowing due to soft plaque, then these methods that are more like the cardiac CTA and the heart cath, that's what's needed to find that, right?
Yeah, and some would argue that a coronary CT angio may define it better than an actual invasive angio. But yes, you would, to get to that level of discernment, you would need at a minimum the coronary CT angio.
On
I
this,
agree.
can you also talk, Dr. Lima, about the ramifications of a piece of data being incorrect or not as accurate, and then whether you can validate it at recovery? So an example would be when we do 3D volumetrics for the heart ahead of time, that's a lot more accurate than using BMI or predictive heart mass from height and weight to determine the actual volume of the heart. If for some reason that is not as accurate as for some reason on that case, you would be able to come there and actually know the size of the heart because you take the heart out. But something that was maybe not determinable as easily. For example, I think you said that calcification, you could palpate and you could feel large calcium deposits with the heart. Is that correct?
Yeah. So, with the heart in situ in the chest, you could certainly assess, and you always do. You never assume, because I mean, even the the low risk. Oh wait, there's no way this person has coronary disease. You may find a plaque or something. So you palpate the coronaries, but ultimately the final, check is when you've actually taken the heart out and you're looking at it on the back table, because that's where we actually have to look at the valves, right? You can't visualize the mitral valve, the aortic valve directly until the heart's out, right? So there's occasions where oh geez, there's endocarditis, or there's something here, there's a vegetation that wasn't seen on echo, right? And so yes, that's the final checkpoint. And some of the—
Does that sound familiar, Dr. Shroff? Remember that?
Sounds very familiar.
And I think, honestly, it was Life Gift, and I think it was Vanderbilt that found it on the table, and it wasn't visual on the echo. And the question came back, but it was like, well, you can't actually necessarily see that, so there has to, and you have that opportunity. That's one of the beauties of organ donation, is that you actually can verify things on the table that you can't if it stays in the body, right? Like that's why, in a way, some of these novel methods of visualization, they're about improving the opportunity to make the right decision to come or not to come, right?
And Lima, can you make a decision about soft plaque at post-transplant recovery?
It's a hard one, because you can only visualize so much on the surface of the heart.
Right.
At least if it's calcified, you can run your fingers along and feel that. But depending on the degree of how much epicardial fat there is overlying the coronaries, or if the coronaries take an intramyocardial course, you may not be able to actually visualize certain parts of the coronaries at all. And so you're limited to direct palpation, and a soft plaque, you may not be able to appreciate any abnormality.
So would you say that, for example, lupus, because it is a proxy towards potential soft plaque, that kind of indication would be areas to be more cautious around just using this CT with the method of calcification?
Yeah, I mean, this is just lumping together two big risk factors, right? And so, again, judgment call.
And I think, Dr. Shroff, you mentioned like a young patient or a young donor that was a lot of drug abuse, and you had a few scenarios where calcification wasn't, as much of an indicator that there was potential for the soft plaque, right?
Yes, and that's where we use CCTA as well, and to look at them, and it clearly defines it very well. And but we were looking, and in the clinical situation, a non-transplant situation, you could do a stress test, determine if it's occlusive disease, and that's all you were interested in. Transplant is interested in other disease, but other than necessarily fixable disease or necessarily fixable disease. So that you're looking for mild to moderate disease, so that will potentially rule it out. I guess my only question with that is whether or not the and this is far afield of what we're talking about today, but I'm curious what Dr. Lima has to say about it. Are we getting better at treating plaque disease and getting regression with with cholesterol lowering drugs dramatically improved, and with risk factor modification in a transplanted heart? Is it going to progress less fast than it did previously with the change in the rejection drugs?
That's a tough question. I would say that there's two processes that may be unfolding in that scenario. One is the native coronary artery disease progression part, and then the second is the chronic rejection cardiac allograft vasculopathy, the vasculopathy
Right.
that happens, and where the reason we get so bent out of shape about the presence of any lumps and bumps, not necessarily occlusive disease, but areas of filling defects, et cetera, is that those have a higher risk of then progressing into or leading to CAV. So it's basically a long-winded way of saying that theoretically, yes, sure, medical management has come a long way, and theoretically, could hold some coronary atherosclerotic disease at bay. But there's also the immune system related, rejection related phenomena that are occurring at the same time. So it's a tough, complicated situation.
Go ahead, do that. You're on mute, sorry.
Fadi Nasrallah, a physician and associate medical director at Life Sharing San Diego, says that really enjoyed the presentation, and I have been asking for CT coronation to offer hearts for our OPO. Please share the data and algorithms so that we can attach it with our offers.
Well, thank you to Fadi there, Dr. Nasrallah, for compliment. Yeah, I mean, sharing the data, that's, I think, what this is all about. I know Lee and others have mentioned that we're sharing the slides, so that's good. There should be also a publication forthcoming, hopefully soon, if we can get it past, the editorial board of the journal we're submitting these to. I think we've also made mention of some algorithms and approaches to help OPOs with navigating kind of the workup for coronaries and donors.
Yeah, and I think we need to be careful. We don't want to make this process, how do you say it? We don't want to apply this in the wrong scenarios and then create this, churn for the donor hospital, et cetera. This is not saying that you want to be asking for or using the basic CT for scenarios that are marginal. If there's calcification, et cetera, it's really trying to get some of the very obvious cases where those are now being offered, and it provides that funnel. We're working with Dr. Lima and others, and we're glad to have other OPOs work with us too on this decision matrix. Everybody will utilize it their own way, but there's a really good process in starting with the screening and then using the different methods in the appropriate area. And of course, there's lots of OPOs that have heart caths, cath labs, et cetera, and we know that still is a gold standard. We'll just move on to the next one. Eric Orozco Hernandez, Professor Cardiology Surgery, Surgical Director, Thoracic Transplantation, UAB. Hopefully you understand this. Positive and negative predictive value of CT.
Yeah, so in this slide deck from last week, when we were talking about the pre-TAVR coronary vetting that's done with CT scan, the negative predictive value is 97% for that modality. it's also mid-high 90s, I believe. We'd have to go back and look at the slides, but the NPV is 97%, which is obviously great. Okay. Which is why I think if you can get a coronary CT angio, that's fantastic, because it's a very powerful study.
Perfect. Okay, Yvette.
All right. Abby Fabian, organ donation specialist at WIDN, says, what have you seen in decline rates when only a cardiac CT is offered? Are centers declining for no cath still?
Yeah, I think so. I would say yes. I couldn't give you hard numbers on that, but certainly centers are still haven't been convinced yet, haven't seen enough data, and are being conservative, which is I can't argue too much with that. But and so at Vanderbilt, we've definitely seized those opportunities wherever possible, where we felt it was safe, and we felt that from a clinical judgment perspective, it was okay. But yes, I think the hope here is that more centers won't decline. But on the flip side, not to be a broken record, but we also hope that there isn't sort of inertia to even do the CT or offer hearts because of the presumption that, well, a cath is they're going to want a cath, and there's no way we can get it. They've already told us we can't get a cath, so we're not going to even bother. I think that's what I hope more than anything we could change here with this effort.
And as a reminder, that was like that between 700 and 1400 F through SRTR, wasn't it? That were never even offered. So this and that's primarily like the DCD, which there's the other challenge of that is that it's a DCD and they may or may not expire, and now you're asking for a heart cath. There's other complications of that, aren't there? Like, whereas if you can be screening with something that's already gotten, you're not actually asking for something, an additional study on a patient that's really in many ways not yours yet from the OPO perspective, right?
Yes.
Is that a fair statement, Yvette?
Yes, that is correct.
Okay, what are we at? Number 12 here. Is this me or is that you?
That is you.
Guang Tsai, medical director, NVLV. How many heart centers use this technique? Boy, that would be interesting. Go ahead, Dr. Lima.
I can't say. I can only speak genuinely for our program at Vanderbilt. Because I think a lot of this boils down to DCD, right? If we're being honest. I know certainly it is largely a team effort too, meaning it's usually at every, as it should be, at many programs. There's a lot of cooks in the kitchen. You have surgeons, you have cardiologists, and often these decisions are programmatic decisions for an individual center, saying, how conservative or not are we going to be? And like I said, this is not really penetrated all the way to all the centers. But I imagine it will. And I think more data is needed. And that was our intent with putting together this manuscript that we've submitted to sort of share our experience with going this route. But I think, through a combination of publishing, maybe changing how some of these images are acquired and processed, I think it's going to just take a little bit of time for other centers to adopt this technique.
Boy, we've got, I didn't realize this last slide had a whole bunch of questions. So we might have to have another webinar. Go ahead, Yvette.
All right. Matthew Bailey, Clinical Operations Manager at Donor Network West, is asking, please address physicians refusing CT cores on DCD patients because of meds needed to get the heart rate down and scan.
Yeah. Touched on this a little bit earlier, but I'd be curious to know why there's a refusal on the physician side, or administering the medication. And as we also talked about, in this situation with a donor, a DCD donor, the concerns about levels of radiation potentially, again, because we're talking about, long-term cancer risk, right, is oncologic risk. So there's a lot out there in radiology literature about nuanced ways to perform these scans to try to limit the amount of radiation. And one of them is if you can lower the heart rate, that means you could get a bigger bang for your buck and not have to administer as much radiation. But sometimes if there's no way around it, there are other techniques as well that can compensate for a higher heart rate and also for maybe an inferior scanner. Again, this is a cardiac surgeon talking about radiology, so I'm by no means an expert or even close to in this, but I think there's some workarounds here that just need to be fleshed out. And it's going to take some time.
Are you also saying on that, Dr. Lima, that those concerns are for people that are going to live on? And so in this scenario, having a higher dosage would allow a heart rate not to be as low?
Yes.
And that would be acceptable in a DCD case?
Theoretically, yes.
Okay. Interesting. Good. Okay, number 14.
Taylor Monk, supervisor at Gift of Hope, asked, does the heart rate have to be below a certain number for this to take place?
Yeah, kind of touching on the same theme here. And there's a spectrum here as far as to what level of certainty and granularity are you trying to determine the coronary burden of plaque, et cetera? Are you trying to determine the as the example I mentioned before, right? If you, in a clinical example of someone with some a plaque in the coronary that's definitely partially obstructing, but is it 50%? Is it 60%? Is it 70%? Because if it's below 50%, we're going to leave it alone and do this other procedure that we have planned. Versus in a donor, that's not really what we're trying to do. We're trying to see, if there's some plaque, soft plaque, maybe depositions along the, we're not, hopefully not seeing like major occlusive disease, right? Because I can't imagine that wouldn't have been picked up on a non-contrast chest CT. So these nuanced things about getting as much resolution as possible, lowering the heart rate. I think this is where there's going to be some opportunity, I think, to, this doesn't make necessarily, this is me guessing, me kind of projecting, but we may not have to do it exactly the same way with the same level as it's being done clinically now for other circumstances.
I'm going to run, we're running out of time here, so I'm going to run through, I kind of seeing some of these are similar. So just relative absolute contraindications, I think we've done that, but thank you, Sergio from Life Gift. Pam Cart from LOPA. This is, I think, a good one. Let's come back to that one. This one here was what protocol or CT do you ask for? We've kind of covered this. Again, thank you, Joe, Duke University Hospital. And Casey O'Brien, life sharing, are there specific requests that should be placed in CT? Again, I think these are combined with the matrix or rubric on what to ask for in the hospital, and that's something that we're working on. Lynn, Director of Performance at Life Gift, how would an OPO improve the information provided a surgeon without a CT?
Yeah, I mean, this is the crux of it, right? Is the judgment call? I mean, I think there's always, or I'm advocating there always should be, and I think it is the case that almost everybody, without exception, has a non-contrast chest CT.
Right.
If what I guess is intended to here is a coronary CT, if you could, with a non-contrast CT, as we've said kind of throughout this webinar, add more to it, maybe the calcium score, et cetera, that could help. That could be additional information with, the minimalist CT, the non-contrast chest. If you could add a little more to that, that maybe help tip the scales for someone that's like, well, I mean, it's 2 a.m. I'm scrolling through. I don't see anything, but I don't know. I'm squinching here. What if there is a white speck somewhere and I'm not seeing it? It'd be helpful if there was an official reading scoring it saying, yep, there's no calcium.
Yeah.
Right.
And that is what CompuMed can provide, is that report, if you will. I think the takeaway here is there is so much that the CT provides. We're just seeing it over and over again. There's so many AI tools, post-processing tools. We just really need to focus on getting the CTs all uploaded early and earlier, not just at the end of the case, but early on, because there are things there's AI that in post-processing that it might take a few hours, 3 or 4 hours, and that CT really can show, can be utilized in so many different ways, and so I think trying to find things without the CT. I mean, there's obviously other modalities, etc. But I think what you're saying is we need to focus on getting those CTs uploaded, right?
Yep.
This is the one, Alicia, thank you so much. There's a lot of questions here. I think we'll have to come back to that. But there's some fantastic ones in here, even grouped into readiness and infrastructure, etc. But we're pretty much out of time.
Can we do one thing real quickly? Sorry.
Yes.
Hey, Alicia, I see you're on here. Congratulations to Connect Life on their record number of lung transplants this year.
Yes, absolutely.
Amazing.
Yeah. Good. Well, that was drinking from a fire hose. Thank you to Dr. Lima and Dr. Schroff and of course Yvette, and especially thank you to everyone that took the time to ask questions. And we'll be sending this out as well. This is just such a rich topic, and there's so many more opportunities here. And we'd be glad for any transplant centers that want to call in and talk about this and things that they want to know on imaging, and of course any OPOs on how to get this rolling. And we'll be following up with more documents and guidance especially on how to request this sort of thing in the hospital to get the technical component, and how to get some of these reports on the interpretation side. So thank you very much. Anything else, Laura? We're good.
Happy holidays.
Happy holidays.
Yes.
Yeah, there is an
Thanks,
example,
everybody.
Lima. We went through years of the serial echoes being questioned, and that now is standard of care. So you're going to get there.
Yeah.
Thank you.
Yeah.
I appreciate this.
Yeah. Just a real fantastic thank you to you, Dr. Lima, for all the work. And they say if you want to get something done, ask a busy person. So Dr. Lima's busy.
My pleasure. Happy to
Thank
help.
you so much.
It was a lot of fun, and I think more importantly, it's to make a difference. So
Yes.
Yeah,
That's
it's
right.
going to make a huge difference. Thanks, everybody.
Very
thanks,
good.
everybody.